you very much, Anne-Marie. Thank you also to Anders and Merlene. We know this was not an easy exercise to talk about your personal experience. We thought it was very important to set the scene with, you know, your speeches, because I think that we already learned two important things. The first is that current treatments are working quite well to some extent. When we see the three of you, difficult to realize that you are a patient. You are like us. So it means that current therapies, current approach, you know, are working to some extent. Now the second lesson is that indeed we must improve. We must go for a cure, because obviously, and you talk about quality of life, we are not there yet by far. So I think that the challenges that we are all facing together with you is indeed to move forward to indeed improve further the way diabetes is handled. And obviously in these partnerships, those taking directly care of you, meaning the physicians, are key. And someone we forget about this. When I hear discussion between industry, research scientists, patients, regulator, I'm wondering, but where are the physicians, you know, who directly interact with you? So I was very pleased when we discussed this with GDRF. They came out, there is one person we should invite to talk about this, and this is Chantal Mathieu. I was very pleased because I know Chantal for years and years. I prefer not to, and actually we did some research together in the past, so I know that indeed she is the ideal person because she is in direct contact and she is seeing and taking care of patients every day, but also she has a huge and worldwide recognized experience in diabetes research. So I will not make the introduction of Chantal longer. Chantal Mathieu is chair of endocrinology at the University of Leuven, KU Leuven, here in Belgium, and she will talk about the clinician's experience.
Yes, thank you, Michel. I feared you might say how old we were, but well, we still feel very young. So it's really a pleasure to be here and give this talk in this symposium organized by the IMI Initiative and JDRF. And it's an honor to talk right after my heroes, namely the patients. Because indeed, you learn to be very humble when you work with patients with chronic diseases like type 1 and type 2 or the other forms of diabetes day to day. When clinicians speak, we're always expected to show our conflicts of interest. Voila. So the bottom line is I am in all the company's international advisory boards, but I don't get the money. It's my institution who gets the money. And then we use it for research, which is nice. Yeah, as Michel said, I have a very special profile, namely I do see patients every day. We have in Leuven 1,400 type 1 diabetic patients. We have 2,600 type 2 diabetic patients, and I don't want to think about how many others that we don't know the type of. But we also do quite a lot of basic research, and so I'm one of the dinosaurs who tries to bridge the gap. And I've been tempted to choose many times in the past 20, 25 years because it becomes very hard and the legs are spreading wider and wider. Because to do basic and translational research, the bar is getting higher and higher. It's going faster and faster, and to have high impact work, you really need a whole group of very good scientists around you. But also in clinic, the bar is getting higher and higher, and it becomes more and more difficult to really do good clinical medicine and treat our patients nicely. But I can tell you that I don't want to choose. And I hope we will still be able to convince some of our young people to bridge the gap between basic research and clinic. Because it is only these bridge people who can talk to both fields that are really driving the field forward. Because if the basic scientists just continue working on calcium channels and the clinicians do something else, we will never cure this disease. So we need to talk to each other. I'm very happy, Mrs. Bevers, I think we think alike, namely when we as clinicians treat patients with diabetes, we need to keep one goal in front of our eyes, and that is we want to make our patients live longer, but also we want to improve quality of life. And what we know from studies is that, yes, sticking your finger, yes, having a pump or an insulin, blah, 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 is not nice, but what really dramatically impacts quality of life of our patients is complications. Chronic complications, but also the acute complications that you heard being too low, being too high. The chronic complications of diabetes, most of you will know them. Diabetes is typically a disease of the vessels, so you will get an affection of the small vessels, of the large vessels. And so this is the reason why the payers now listen to us, because they see the whole type 2 diabetes world exploding, and they see the cost rising. And they realize that no healthcare system will be able to carry the burden of diabetic complications in future. So that is the reason, well, also noble reasons, of course, but still, that is the reason why the payers are now listening to us and say we need to do something about prevention of type 2, about prevention of type 1, and curing these diseases. Oops, I'm going backwards. Complications. Chronic complications, everybody gets it, but also acute complications dramatically impact on the quality of life of our patients. What we don't want to say out loud, but hypoglycemia, the acute complication of some of the drugs we use in diabetes, insulin, sulfonylurea, is also a killer. We lose patients. We have young guys not waking up in the morning because of a hypo during the night. And we forget this, but it is a reality. And I can tell you the names of each and every young guy I have lost in the last 25 years because of this. It's a thing you don't want as a clinician, but it happens. Because we want to bring down glucose as much as possible to avoid the complications of the vessels, the eyes, the kidneys. And we realize we push the system to the edge. And we realize that in some people we expose them to very dangerous hypoglycemias during the night, but also during the day, preventing them sometimes from performing some jobs, like driving a lorry or whatever. And I know we need rules on driver's license in Europe, but still, it is hypoglycemia that is preventing some of our diabetic patients to have a driving license and to do some jobs. Or the opposite. Patients don't tell the doctors anymore that they have hypoglycemia to preserve their driver's license. Hypoglycemia is an issue to patients and also to doctors. This is a study sponsored by Novo Nordisk called the GAP study, where they asked patients and physicians whether hypoglycemia affects their behavior. And indeed, also doctors are very aware of hypoglycemia and taper down therapies in order to avoid hypoglycemia. So, therapy of diabetes, type 1, type 2, type whatever, what we are really doing as clinicians is therapy of risk factors for complications, acute and chronic. And chronic complications, we have glycemic control, but there's also macrovascular disease that is more prevalent. Myocardial infarction, stroke in people with diabetes, mainly type 2 diabetes, but also our type 1s have an increased risk. And there, of course, just scratching glucose alone is not enough. There we need to tackle the whole disease with also blood pressure and lipids and lifestyle, etc. Cancer is something that has appeared in the last years. We knew it, we saw it, that indeed, as we treat our patients better and better, cardiovascular disease is prevented, dialysis is prevented, but we see cancer emerging. And we have insights now that obese people, type 2 diabetic people, have more risk of certain cancers. And that is also a thing we need to take into account as clinicians. Let's go back to the therapy. How do we do it? The typical type 1 diabetes disease, where it's we think, an autoimmune disease. Beta cells are being destroyed by the immune system. The beta cell itself probably has an important role. And so what do we do as clinicians? As you've heard from the two young guys, we measure blood glucose, we think, and we inject insulin. We actually replace the beta cell function by our head and by some tools. And more we are doing this more elegantly with sensors and pens, but this is actually still what we do. Namely, we learn our patients to do externally what normally automatically is done by the beta cell. And so if you look at our tools for type 1 diabetes, there's insulin, there's education, self-monitoring, blah, blah, blah. But if you look at the weight of these tools for the quality of life of our patients, we need good insulins and we need good education and self-monitoring blood glucose. That's what the patients need. Then they can do it themselves. Lifestyle diet, they can do whatever they want as long as they are able to really control their blood sugar with the external tools. This is a picture given to me by one of my type 1s. He said, Dr. Mathieu, this is what I experience daily. I feel like walking a tightrope. I know that if I go too high, I will have complications later on, but I know that if I go too low, I will have hypoglycemia and the crocs are swimming in the water. And all kinds of things, stress and food, and the story of the sports is very nice. What Marijn told us, you know, if I'm too high, I will go higher. If I'm low, I will go lower. So it all impacts on the glycemic control. And this is, for instance, a readout of sensors that Marijn and others are carrying that we see. Reality is quite confronting when you see then how glycemias are, even with our fantastic new insulins, even with the pumps. Type 2 diabetes is a very different disease where you have a dual disease, beta cell failure and insulin resistance, and the beta cell fails because of different reasons. And what is important is that in type 2 diabetes, there is always a component also of insulin resistance, thus predisposing people with type 2 diabetes even more to the cardiovascular risks than people with type 1 diabetes. So type 2 is really a multifactorial disease where glucose is one player, but where all the other risk factors are surely as important and where therefore the macrovascular disease stands on the forefront. And so if we think of type 2 diabetes in the heart, it's all these factors and glucose. So if we think of making a cure or affecting type 2 diabetes, glucose is important, but all the others might be as important. And so if you look at the tools for our type 2 diabetic patients and the weight we give them, it's really education on lifestyle and diet. It's the multifactorial approach, and all the others are a little less important. And what we as clinicians have done many, many years is just copy-paste what we know from insulin therapy in type 1 to type 2. And more we're learning that this is not the way to go, that type 2 diabetes requires a different approach in insulin therapy than type 1 diabetes. Instead of putting everybody on multiple daily injections with insulin, we might add something else to the basal insulin therapy. And so more we are looking at the GLP-1 receptor agonists, etc. We live in interesting times. Dick said it, Michelle said it, a lot of things are moving forward. The smart insulins, the sensors, the pumps, our research, oral insulin, everything is going forward. But let me just end by giving you my ideas. If we look at what's happening, you know, the pipeline on oral antidiabetic drugs, phase 2, 3, regulatory, blah, 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 there's a lot coming. This is new insulin. Also in insulin, a lot is going, and also oral insulin, smart insulins, everything is moving. So we are living in interesting times. What are the current trends? Well, you saw the two guys. Everything is becoming electronic. I have a pump, I have a this, I have a that. Patients go on the internet, have apps measuring. I do like this because I also have the app, measuring how many steps you take, the calories you take a picture and you know the carbs in your plate. So for people born in the 60s, it's quite impressive. Pumps and sensors, more and more evolving. We know that we can close the loop as long as people don't eat. So our sensors can drive the basal rates of the pumps, making really almost flat glycemia as long as you don't eat. Our sensors cannot cope with the delay they still have and the food intake. But during the night, it looks fantastic. But this is the reality. You had two guys having a pump, a sensor, blah, blah. Don't think that this is the standard. Don't think that this is the standard. Here you see pump penetration in Europe. Belgium, 7%, not 1 in 10 of our type 1s has a pump. Not 1 in 100 has a sensor. So when we have this impression, but type 1 diabetes is solved, we have sensors, we have blah, 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 it's not solved for everybody. Yeah, this is the reality. And so Norway, who leads the pack, has 46% pumps, but still 1 in 2 who doesn't have a pump. And the pump isn't the solution for everybody. Some people don't want this pump. Yeah, so this I already said, apps and informatics and what have you. But this is the poor clinician. When our patients now come to the clinic, and these guys to come to the clinic, we used to have people with sheets or with little booklets with the glycemias and 5 or 6 glycemias a day. Our brains could cope with that and analyze it. Now these guys come to us and they just vomit thousands of glycemias every day. And so we cannot analyze them anymore. We need new tools to do pattern recognition to help us in decision making, because we have data overload. And I hate it when a new company comes to me and they say, oh, we have something fantastic now. When your patient measures his glycemia, it's sent right into your email box. I don't want them. You know, I cannot follow the glycemias of 1,400 type 1 patients. So we need to think of ways to really cope with this data overload also. Finally, what are the unmet needs? I talk a lot with patients. I was chairwoman of the patient organization. I've been with JDRF for many, many years. And so what is clear that is, in the end, clinicians and patients actually want the same thing in the end. We want to beat this disease, but we also have some shorter needs. So what is urgently needed? Understanding of diabetes management. Help patients become experts. Give them new educational tools, calculation tools. All patients, not only clever guys like Marijn, and it's not clever. I have some very intelligent people who just cannot do it. I'm going to say something strange. You cannot be too intelligent to cope with type 1 diabetes, because otherwise you freeze if you know what hangs above your head. So we need tools to have everybody on board. Access to diabetes specialists. It cannot be that in a country like Belgium, type 1 diabetes children are still treated by pediatricians who have one type 1 diabetic child in their population. They need to have access to diabetic specialists. Labeling of foods, absolutely, Europe, go. Take care of social hurdles, think of the driver license, and then access to education. This is a picture I took from the website of the US Marines. No one left behind. That's their slogan or logo or what have you. I like it that JDRF says, well, pumps and sensors and blah, 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 and fast. Everybody has a right. Also people who cannot calculate. Also people who live in countries that cannot afford sensors like Belgium. Also people who live in countries that have no access to the best insulin analogs. You know, no one left behind. Our tools need to be there to have everybody with good glycemic control. And then finally, imagine. Well, if I can dream and say, what do we need? We need less fluctuation of glycemias for our type 1s, less hypos, less hypers, flat glycemic curves. Insulins that give less weight gain, and then, yeah, if we can cope with it, no injection. And also, injecting insulin is less painful than measuring your glycemia every day. You have to do it. You have to do it. Do it. 1 week, just measure your glycemia and you'll realize it. Glucose-sensitive insulins. Oh, yes, the smart insulins. Then we solve everything. Well, we hope. No hypoinsulins. Painless glucose values, continuous values. Of course, intelligent pumps, the closed loop, but also cheap pumps, you know, available for everybody, not only the rich countries. And then I couldn't resist Michel and Dick. Yeah, we need money to study this disease that is type 1 diabetes, this disease that is type 2 diabetes, to be able to predict who will get it, to predict, once you have it, how you will fare, to be able to stop it and to be able to cure it. And then social unmet needs, I want to end with this awareness on diabetes. And type 2 diabetes has saved us. 25 years ago, when I saw a new type 1 diabetic person, I needed to explain what diabetes was. Taboo, the family didn't want to know. Oh no, nobody could know it. Now everybody knows somebody with diabetes because of type 2. And that's a good thing, because now the teacher has diabetes, and so it's not a problem anymore for the kid to have diabetes. So awareness is very important. Access to endocrinologists, absolutely. And be aware that the face of diabetes is changing. Type 1 in elderly, type 2 in children, unfortunately. So I end with this slide. I do believe we live in interesting times. It's not my statement. It was said by Bobby Kennedy in South Africa in 1966. There's a little asterisk also. It's also a Chinese curse, apparently. May you live in interesting times is what Chinese wish you if they wish you a very hard life. But we're willing to take this on and live these interesting times.